Steris Katsoumaris, who's still head of the department here. And it is poignant that he's one of the directors and not with us any longer. I also thought that last night's ceremony in his honor was really very special. Well, I've been asked this interesting and I think now becoming more difficult question. Essentially, the hypothesis is that the distal venous bypass is now better and still remains to be better than fixing a distal circulation with the new endovascular technologies in diabetic patients. And I think that we need to very clearly state that these are diabetic patients who have severe ischemia. And the hypothesis is based primarily that these grafts are going to be better in the high incident distal disease. But I think that much of what we're dealing with really comes from historical data as captured here in the American College of Cardiology and American Heart Association practice guidelines, where the observation was made many years ago already that femorotibial vein bypass does substantially better in terms of patency than a graft that is done with any other material, and at a time when endovascular interventions were considered to be taboo below the knee. And this is the reason why, in fact, we still have these recommendations here from one of the surgical doyens in North America, Michael Conte, who still, in his recent publication, indicates that if individuals have a limited life expectancy, not a lot of disease, and have lesions that are amenable to endovascular repair, and particularly so if there's no suitable vein, that an endovascular procedure is performed, essentially basically making the statement that this is a lesser procedure compared to what one would expect with a good quality vein. Now, the question that really needs to be asked is that, in fact, the case? And here we're talking about patients who have popliteal artery trifurcation and crural artery occlusion. We're not talking about those individuals who have occasional stenoses in which a guide wire is going to pass quite easily. And I think that the first thing that we really need to state, and this is, I think, the new paradigm, and I'm a little concerned that some of the discussions this morning around the outcomes related to the balloons and other endovascular technologies are still talking about patency rates and not limb salvage. We have to be looking at limb salvage. That's the endpoint that we're trying to achieve. And if we look at the information that's available to us in regard to the question being asked, there really is only one randomized trial, namely the Basel trial. And in the Basel trial, approximately a third of patients had infrapopliteal disease and a third of patients had diabetes. But what is also important in this trial of 452 patients is that even in the late data and the reanalyses, that there's no subgroup analysis. So we don't have randomized data to really help us in answering the question. The one thing that we also need to recognize that if we're going to use that data, that diabetics and non-diabetics do differently. In a talk that I gave to this society in 2012, I demonstrated very clearly that in bypass surgery, that the diabetic do worse, both in terms of limb salvage as well as in terms of survival. But can we then also say that is true in terms of what happens in the endovascular environment? And I would contend probably on the basis of the data not. So this is the headline finding from the Basel trial, which looks at amputation-free survival. This is the data now after a minimum of at least 50% of the patients having had a 5 years follow-up. And if we look at the outcome at 5 years, there's approximately a 40% limb salvage, an amputation-free survival in those patients. I'd like you to, however, also look at the limb salvage rate in that study at 1 year, which is 88%. Now, looking at the other component of that study, looking at overall survival, there's this evidence now that patients who've had a bypass tend to do better in the long term, whereas the individuals who've had an endovascular repair tend to do better in the short term. And the interesting thing here is that what's important, and this is the subgroup analysis per protocol analysis looking at amputation survival, is that successful angioplasty or successful bypass surgery do better than in the short-term failure of angioplasty and surgery. So it's important that there's something that is successful, and that presumably is probably the most important decision even in the femorodistal environment. So in this particular subset of patients, I don't think we have any data for us to draw a valid conclusion. It is very clear also that to get a good surgical outcome, that there is a requirement for good surgical, for a good quality vein. That is data that is in the Basel trial, which I haven't shown you. So what other information is available to us? And I'm just going to very rapidly take you through some of the non-randomized data. So tibial artery angioplasty has been shown to have a reasonable level of limb salvage, despite the fact that primary patency is not particularly good. In this well-known study now by Romity, which looked at a pooled analysis of nearly 2,700 patients, while primary patency over the short to medium term was not all that good, limb salvage was well over 80%. Now compare that to the same data out of Basel, and you can see that we're talking about roughly the same information. If we do that in terms of the crural bypass, again, a pooled analysis in terms of crural bypass surgery, a big difference in terms of primary patency versus limb salvage over a period of time. And while it's not as big as it is in terms of the endovascular, the difference is not as big as in the endovascular environment, it still is roughly 20% at 5 years difference. Tibial artery angioplasty versus femorodistal bypass. In this, I think, not particularly good study done in Holland, where they looked at a large number of studies in each one of the two treatment modalities and find that the limb salvage, in fact, is roughly the same. And again, in the pooled data, limb salvage at 1 year, roughly 82%. And then finally, this is a analysis of the work that was done in Helsinki over a 7-year period. Again, trying to compare the two. It's obviously not always possible to look at in terms of exact information about those patients. But interestingly, in terms of amputation-free survival, whether they did bypass surgery and angioplasty, and when they did some correction for the variations in these groups, they found a very similar kind of picture. So in conclusion, colleagues, I believe that the increasing successful use of an endovascular approach to infrapopliteal disease, the fact that there is no randomized data, but where it appears that infragenicular endovascular interventions appear to have the same, or at least similar, limb salvage rates, I believe it's no longer possible to support the hypothesis, and primarily because graft patency is not equivalent to limb salvage. We really have to start looking at limb salvage, and I think that that's the criticisms that we need to now again be looking at the data that's in front of us in the endovascular world. What is important in this circumstance, I think, is that we have to heal the ulcer, and it really doesn't matter what that look and that blood vessel looks like when this is healed, as long as they've got a walking mechanism. I appreciate your attention. Thank you.